Hi, good evening, everyone. Welcome back to our another session of our webinar, and it's towards the end of the year end. So this is probably our second last. Next week will be our last. And I made a mistake. Actually, this webinar, I booked it with Dr. Hamanchin last week. Somehow or other, I made a mistake and then I wrote it down on the 27th. So sorry about that, Manchin. But thank goodness that you are able to make it today. So without further ado, we go ahead with your spot diagnosis.
Yes. Okay, so I should I share screen now or no need?
Yes, can. You can share.
Is it a full screen now?
Yes, it's a full screen now.
Okay. Hi, good evening, everyone. I'm Dr. Hamanchin. So thank you, Dr. Betty, to invite me again for this.
Yeah, I always have so much
I
fun.
always like to do spot diagnosis because just showing X-ray and then revision with everybody and to see whether the findings is obvious or subtle findings that everyone can pick up. Okay. So some of the X-ray, maybe one or two I have shown in previous sessions. So hopefully you guys can detect the abnormality this time. So please, I have to invite everyone here to join our session. Please type your answer in the chat box in the Zoom meeting chat so that I can see your answer, or you can press, you all are muted, right?
Yes. Oh, mute.
So
Maybe
you
it's
need
better
to,
to press the what?
yeah, you type your answer in the chat, meeting chat box, so at least I know that you are listening and you are trying to look for the
Yeah.
abnormalities, and will be a more fun and interesting sessions.
Yeah,
Okay.
let's make it interactive lah.
All
But
right.
okay.
Yeah. So let's start with the first slide. So this is a PA irregular chest X-ray, and this is an easy one. So I need some answer from the floor. Okay, Jachi, very fast.
Yes.
I think right? She answered quickly. There's a pneumoperitoneum on the right, under the right hemidiaphragm. So is my arrow moving?
Yes,
Right?
arrow is moving.
So this is the, on the left, okay, on this X-ray image, so the right side will be labeled on our left-hand side. So this will be right side of the patients and then left side here. So underneath the left hemidiaphragm will be our normal gastric bubble, okay? So when there's air underneath the right hemidiaphragm, this is abnormal. And also you can see the air tracking towards the midline as well. So this is a pneumoperitoneum, okay? This pneumoperitoneum, we must do a chest X-ray, PA erect, or even AP sitting sometimes can detect as well. Okay, so I believe no one should miss these findings. Okay, this is our bread and butter every
Okay.
day.
Can we just maybe tell maybe some medical students or junior doctors, what does this indicate, the pneumoperitoneum?
Okay, so this pneumoperitoneum meaning there's some perforation of the abdominal viscus. So there's intraluminal air which is supposed to sit inside the bowel lumen that tracking out from the bowel wall or stomach wall that leak out to the peritoneal cavity. So on X-ray, it will show the air outside the bowel lumen. So this pneumoperitoneum.
I
Okay.
think, yeah, I
Dr.
think
T
it's not
answered
very
PG.
common right now to see perforated gastric ulcer, yeah. Because we
Common or not uncommon? It's not
not
uncommon.
common so much now because we have so many medication to treat gastric ulcers these days. But I think about 20, 30 years ago, when I started my career, we still see it as a medical emergency. But now I don't think I've come across one, especially with now the PPI in the market.
But I guess in some district hospital, you
That's right.
can
Of
see,
course. Yeah.
not only in our big city here.
Mm.
Okay, so everyone, please remember this pneumoperitoneum. Even though when you see the X-ray, it's sometimes very subtle, just little bit line here that raise your suspicion, correlate with clinical findings that patient having intense abdominal pain and unexplained pain and all that. If you're really not sure, go ahead and request a CT abdomen pelvis, which will give you a definite answer for this. Okay.
The abdomen will be tender, guarded,
Yes.
and rebound, yeah?
Mm.
Okay, let's go on.
As next X-ray. Okay. Okay, this is an easy one. So I need an answer in the chat box.
I don't even know which part of it is the X-ray.
Which part? Okay, please tell me which part of this
Okay.
human body.
The fracture of the coccyx, Jiayi.
Jiaqi. Okay, good.
Yes.
The fracture you can see. Hang on. Okay. So this is a sacrococcygeal. We must have a smooth alignment. You must always draw the line following the bony outline here. So whenever you reach the coccyx here, there's fracture. You can see there's fracture and then dislocated. Okay, down here, this part. So, but clinically, patient definitely will have a fall and then pain at the buttock. Okay, so always when review coccyx X-ray, must always draw the outline, then you will know there's fracture or there's dislocation. Okay, so going to the next X-ray. Okay, what about this? This is a pre-op chest X-ray, pre-operative assessment. So basically, patient is asymptomatic.
It's normal.
It is not normal.
Okay. Try my luck. Okay,
Yeah,
one can see.
this X-ray I've shown in last session.
Oh, I'm looking.
I will need an eager eyes to find the abnormalities for this X-ray.
I think it's the right cardiac silhouette.
Still acceptable?
Okay. Is there a collapse of the lung?
No, no collapse. So can someone type in the chat box? What's your findings?
Anyone? Jiaji?
Jiaqi or R, somebody named R or Dr. Siti?
Okay. Anyone at all? I can't see it. I only think that the cardiac silhouette.
Okay, so when we can't find any abnormality, always remember to look again at our review area, right? Review area. So from the lung field, both sides first, whether the intensity or opacity, whether it's fairly symmetrical, whether there's any opacity in either side of the lung fields. Okay, if there's none, then we look at the costal phrenic angle, both sides.
Oh,
When,
okay.
yes, Jiaqi, yes, right apical pneumothorax. Okay, see, when you see the review area again, the apex, then you will look at this purer line here.
I see.
So there's a very minimal right apical pneumothorax.
So the patient is going for op that is not related to this.
Not related at all, just incidental findings.
So this patient has had pneumothorax, must be for some time now.
Yes.
Oh.
So it's minimal and repeating for a few times. Done CT also, there's a pneumothorax. So again, reminder from this X-ray will be the review areas. Look at the opacity, bilateral, symmetrical, costal phrenic angle, the next apical region. So once you scrutinize this region, both sides must compare, then you will find the abnormalities, okay? So after the apical region, remember will be the mediastinum. paratracheal region first, and then mediastinum, then hilum, make sure it's symmetrical and there's no nodular opacity here. Then coming down to the cardiac silhouette, and then next will be the retrocardiac region at the back of the heart shadow, and also this adjacent to the right heart border, and then going to the paraspinal region. So then next will be the bone, one by one looking. This all will be our normal daily review area. Okay, because not all findings that we can find it in at a one glance or single glance. Okay, so most of the time we will need review area, but when we find something on the X-ray, so we still go through the review area just to make sure we don't miss out anything else. Okay. Okay, good, Jachi, you can answer this. Come next. Okay, what about this?
Okay, the abnormality is over the right side of the lung.
Right side of the lung, there is some more. This one also a revision for our review area. Come on, guys.
Actually,
Right lung, so we will see there's some opacity and reticular changes, right?
yes.
All right, here actually at the left lower zone also, this is all the fibrotic changes. So I won't show you just fibrosis. Where else in this X-ray? Okay, go through review area again, everyone. Start from apical, any apical pneumothorax. So for this case, there are none, right?
Yes.
We don't see any purer line, obviously. And then coming down again, the lung feels fairly symmetrical. And then this one we already detected on the right side, and the left also there's some fibrotic changes. Also, phrenic angle, both sides actually fairly clear. Still sharp, there's no pleural effusion. Retrocardiac is still acceptable because this underpenetrated a little bit. So going through the mediastinum, paratracheal region, okay. And then mediastinum here, fairly normal, right? No widening. And then cardiac silhouette also preserved. But look at this aortic arch here. Is smooth, it's normal. But then look at this above the aortic arch, there is a lesion here actually, hiding over the consider paraspinal region above the aortic knuckle. So this is a very subtle finding. So next I will show you his CT scan. So you see on the CT scan is show the lesion here. This is a primary lung tumor at the left upper lobe. So look again, the X-ray, it is very subtle, correct?
Yes.
Very subtle. So we go back to another patient just now. Okay, look at this patient. You see the above the aortic knuckle, that's actually fairly clear. So that's why we must really, really look hard to see if there's any abnormal opacity basically on a chest X-ray. So from compared to just now the normal, when you see here, then you will notice there's actually opacity above the aortic knuckle. All right?
Because when you focus on the fibrosis and you thought you got the diagnosis,
Yes,
you
yes.
will miss that.
Yes, but this one is to show just a reminder for us to look carefully, because I don't think at first glance I may miss it also, because I'm retrospectively looking back to this X-ray from the CT actually.
I see.
That's why I can see it, but that's the point that I want to bring up this X-ray, just to show everyone we shouldn't miss this area for next time when we see an X-ray. Okay.
Yeah.
So there's also another nodule here actually. Is the surrounded to this primary tumor here. This is a nodule also.
So if you go through your systematic review of every area, despite that you have found an abnormality at certain area, you still must go through every single step of your
Area.
area, right? Yes.
Yes.
That's the lesson here.
Yes.
Okay.
So because for juniors, when normally patient will come first to see you first, and then you order X-ray. You may be the one who first looking at the X-ray, not first sometimes. So it's very important for you to scrutinize one by one, and then if there's any small opacity that you're not sure, like you raise suspicion, please go ahead and do a CT scan. Even a low dose CT thorax, just a plain, then you already can detect the lesion. Okay?
Okay.
If not, then we will miss this size of quite small primary lung tumor, but we will progress very fast. Okay, so next again, this is a CT of the same patient showing there's a mass above the aortic knuckle here. Okay, so next. Okay, what about this? I will expect answer from the floor for this case.
Cavitation right lung.
Okay, correct. Some more, lung mets, okay, some more.
Are the bones, I think, a bit lithic.
Bone stability, still okay. It's over penetrating.
Okay.
Hmm.
Anyone else?
Anyone else? Come make a guess.
What is RT in the right?
Yes.
What does that mean?
Betty, can you see it?
Huh?
Lokman, very good.
What is RT?
Rice tube.
Oh, okay.
The rice tube, where is it?
Okay, yes. I see it now. Actually, I
You see,
saw it. I saw it. I thought it was
I
just,
didn't realize, right? Sometimes.
yes.
Yes.
Well,
So
yes.
yes, rice tube, very good. You detect it. So this chemo pot, okay, everyone know is at the correct position in situ. Normally the tip should be at the junction between the SVC and then the right atrium. So this one is a fairly good position for this chemo pot catheter. So now you will check the other tube, which is supposed to be rice tube, but it's coming down to the right, which is supposed to go down here and then to the gastric outlet here on the left side. So this is a malposition of the NG tube.
So the NGT went where?
To the right bronchus going down.
What do you mean? So they
It's
intubated
malposition. Yes,
they
yes,
intubated the
NG tube.
the NGT.
Yes, so
Don't
okay, everyone.
doesn't the patient gag?
Hmm?
Won't the patient gag?
I'm not sure, but this is the X-ray.
What? It's very uncomfortable to have a tube into your trachea and
Definitely, definitely. Someone is not intubated though, just the
yeah,
NG
of
tube.
course.
Yeah. So this one already immediately informed the primary team, and then they already readjusted the NG tube to the correct position. So luckily they haven't started to feed anything yet.
Oh
If
my
not, it will be
God.
aspiration pneumonia. Okay, so remember when an X-ray showing to you with lines and tubes and everything, you must see and outline it one by one to make sure it is in the correct position. Okay?
Wow, this one I cannot. Oh,
Yeah.
wow.
Okay.
Well done, man.
But then this X is very nice X-ray. I must keep it.
Oh, look, man,
And
very
I
good.
must show it to you guys. Okay.
Okay.
Okay, good. So remember lines, whenever we see the lines, either is internally put or external artifact, we will try to figure out the lines first. Then only we go to the lung field so that we won't miss out. If we just look at one glance and then we don't see it like clearly one by one outline it, we may miss it actually, correct? We will think, it's quite okay, but then we miss it. It is malposition,
So
okay?
the tip is this is the tip at the bottom there, this one?
This is a tip, quite lower down already, you see?
Wow.
Yeah. Okay.
Well, if
See?
it start feeding, I cannot imagine, man.
Yeah, it will be a disaster, I think. So sometimes the NG tube is in, but it's just stopped at the distal esophagus. Sometimes it's here. Also, it's considered malposition. So you have to inform them and to put it deeper and then into the gastric outline. If not, the patient will have aspiration pneumonia also. Okay?
Is it common practice to get a chest X-ray for every rise tube?
Mostly, actually not supposed so, but I've seen a few that request X-ray post-NG tube position because you need to auscultate, right, for the sound when you
Yes, that's right. That's right.
But sometimes we do get X-rays for NG tube position.
Oh, I can't remember anymore. Okay.
Okay.
Well, this is a
Okay.
very interesting case, huh?
Very interesting case. Okay. So remember, look at the lines first before we proceed to the lung fields. Whenever there's
Now
lines.
I can see the line clearer and clearer by the second. Just now I
Okay.
still cannot appreciate.
Cannot appreciate. You see the lines
And
now.
now I can. Now I
Mm,
see it clearer and
following.
clearer and clearer.
It's supposed to be coming down here, going to the left, stop here, or even deeper. Okay.
Okay.
Right. Come next. Okay. What about this? An easy one.
Okay, this one. Okay, come on, guys. Since
Come
you all
on.
did so well
The answer.
already.
Yeah. This is an easy one.
There's a lytic lesion
Yes.
over the.
So there's a lytic lesion here at the proximal left. Okay, look at the marker, left femur. Okay, this is a lytic lesion. Can you see? So
Yes.
you see the lytic changes here involving the cortex. If you're not sure, then you compare the rest of the cortex. This one is lytic. There is also periosteal reaction outlining the cortex here. This is bone mats. Okay, so remember when you look at the bone, not only fracture, but also the lytic changes, and then outline the bone again, then you will see the periosteal reaction. If you don't outline, you just have a glance very fast, we will miss the periosteal reaction. Sometimes we don't see the lytic lesion, but we will start seeing some periosteal reaction. So we must see it one by one and slowly. Okay. So this is a mass. So differential for this case, if without a known primary tumor, then will be osteomyelitis. So osteomyelitis and mass normally will be the differential diagnosis when we see lytic bone lesion in adults. Okay.
Okay.
So going to next X-ray. Okay, what about this? Focus at the carpal bones.
This one is beyond me.
Beyond you.
I cannot come up with description. Not that I not
Can
on
you label the carpal bones for me? Okay,
me.
what
Impossible. Impossible. Why do you think I did cardiology?
Yeah,
Cardiology has
revision,
three
revision. Who knows,
arteries.
some
That's all I
your
need.
relative come and ask you, what is this? Okay, so
Anyone?
everyone else, I will show you the anatomy. You just type me what is the bone name. Is it okay, everyone? Come.
Okay,
What
okay,
is this
come.
bone?
Anyone? Got
No,
lateral X-ray. Don't talk about lateral X-ray first.
good. You ask for lateral is good, but there's no lateral X-ray in this case. Okay, what is this bone? Sorry, this one. What is this bone, Betty? It's easy.
Okay, radius.
Radius. Yes, good. Radius.
So the other one must be ulnar.
Yes, so this ulna.
Okay.
So on top, just above the, maybe distal to the radius, what carpal bone is this?
Oh, this one I cannot anymore. I really cannot.
Okay, Dr. Elena, come. Scaphoid. Scaphoid.
Okay.
Good, Jachi. Okay, good. So this one, after scaphoid, lunate. Okay, lunate.
Okay.
Scaphoid, lunate. And then here,
Now I can't see your what? Your
this one,
marker. Okay. Not that if I can see also, I won't know. I really won't know.
trichotrum. Trichotrum. So that will be a pisiform overlapping on the epiview. Okay. And then after that, what about this?
Oh, Elena.
We have 8 carpal bones. Alina, what is this? Or other people? Okay.
Anyone?
So this is a trapezium, trapezoid.
Shafika, good.
Trapezium, trapezoid.
Okay.
This one.
This one?
This is start from C, capitate. Yes, capitate.
Ah,
And then this will be the hamate. Yes, very good. Okay, very good. Okay, so from this X-ray, we learn about anatomy first, but next will be the disease that I want to show you here is you look at this lunate, it is very dense. So it is sclerosed, but we don't see the flattening and all, we just see sclerosis. So this is an avascular necrosis of the lunate bone. Patient will have pain, presented with pain, wrist pain or proximal palm pain. Normally it's wrist pain. So this is a Kienbock disease. Every end of the lunate is not supposed to be dense. The bone density should be same as the rest of the carpal bones. Okay, this one on the pisiform and triquetral look a bit denser, but because of the overlapping bone, but this one is abnormally dense. Okay, Kienbock
okay.
disease.
Just now, G asked for a lateral X-ray. What is the indication for that?
Because normally for bone to look for joints and all bone X-ray, we must always do AP and lateral
Oh, I see.
that we
Okay.
don't miss any fractures. Okay. So next, this easy one, mammogram, MLO view. So where is the abnormality? Just tell me where is the position of the abnormality, location.
Left,
Yes, left.
dense calcification.
No, there's no calcification.
This is the first time I'm looking at a mammogram picture.
Benign calcification, this one.
Yeah.
So on mammogram, remember the position will be, this is an MLO view. Okay, so we draw a line from the nipple going up to this one, the pec major here. Okay, so, sorry. So this part will be upper half and then area below the line will be lower half. So on this abnormality will be the left upper or mid region here. So we will need a CC view for the next position. So this is the same patient. So you'll see the abnormality on the left side again. Okay, this is at the outer quadrant. So the exact location of the abnormality will be left upper and then outer. Okay, you'll see there's irregular high density lesion here compared
So
to the
this
right.
density is not a calcification.
No, this is a mass.
I see.
Calcification will be like this dense, but this is a benign calcification because only single round dot here, but this whole thing is a mess. You see, compare with the contralateral side, you don't see anything here. But then this is very dense and irregular. Okay. All right, so we go faster. Okay, what about this X-ray?
Okay, anyone?
Anyone?
Is it over penetrated?
No, this is a good X-ray.
Really?
So what's the abnormality? Something wrong,
Okay.
right, with this X-ray?
Okay, sclerosis.
Yes. So the whole bone, all the bones are sclerosed, increase in density. This is
Oh,
a
I see.
extensive bone mass from prostate carcinoma.
The whole spine.
Whole spine and ribs and everything else, scapula also, clavicle also is abnormally dense. So this is a sclerotic bone mass.
Oh my God. So
Okay.
that's why it looks like overdense.
Yes, it look overdense, but it's not normal. So sometimes we think it's like, is it the X-ray issue? But no, this is the real pathology. Okay.
Oh,
Yes. So see, compared to this, you see the bone is not that dense, right? It's like smooth, like normal. But then going back to the X-ray, this one, you will see it's very, very dense. So this, remember, don't take it like it's like under penetrated X-ray so that the bone looks dense, but because you can still see the lung field quite fairly not so opaque, so it is bone density issue. Okay, everyone.
okay.
Okay, come next. Going very quickly. Okay,
Okay.
this is the AP erect view KUB X-ray. So when I say KUB, so it's the time to look for
Kidney stones or bladder stones?
stone. Okay, so where is the stone? Anyone, where's the stone?
In the bladder?
In the bladder. Actually, right, a bit dense, right? But actually it's not.
It's so
Initially, I thought this is a stone, but actually it's not. So,
kind to me.
so for
Anyone?
this KUB X-ray, we must, okay, come.
Okay.
This the kidney outline on the left side and then on the right side here. So always look for the stone at
Oh,
this.
somebody said, Java Rahman said, right uteric
Yes,
stone.
yes, there are a few answers already. Very good. So we'll check the ureter following the transverse process. So you will detect the stone here. Can you see?
Why? So
Okay.
actually, renal stones are not so opaque.
Then we will miss it, lor.
Yeah, it's not as like it's not
Gold.
like calcified stones.
Not
Yeah.
really calcified. It's actually calcified, but on X-ray you will see like this kind of density
Oh, I
only.
see.
Not the dense as this marker. Not as dense as this marker. Okay.
Yeah.
So very good for those who found the stone. So always
Well done.
remember looking at the renal fossa and then checking over the transverse process. Okay. And then outline here and then going to the bladder underneath here. Okay. So next, come. Anything?
Scoliosis.
Scoliosis, okay. Definitely not showing you scoliosis.
Okay.
This is our advanced spot diagnosis class.
Advanced, but for the
Yeah.
cardiologist, can only see scoliosis. Okay, I try, huh?
Yeah. Come, everyone. Actually, it's a normal variant, not really a pathology.
Ayo.
It's a normal variant.
Anyone, please help me out here?
Yeah. So again, nobody answered, then we have to start looking at the review area, right? Apical, lung field both sides, costophrenic angle. Okay.
Okay, right esophagus lobe.
Azygous lobe. Yes, Jiaqi again. She got the right answer. So this is the azygous lobe.
Wow, so clever like you guys. I didn't
Yeah.
even know there's an azygous lobe.
Yes. So this normal variant is not abnormal and it occur in 0.4% of all the X-ray. Okay. This is a part one MRET part one exam question or even FRCR. Okay.
Is it because there is a linear line that is coming
Yeah,
down
this
to
is the linear line.
Oh,
Yes.
okay.
So this azygous lobe. Okay, very good. So next. Okay, what about this? Patient came in with a hand pain, no history of trauma.
There is some soft tissue swelling
Where?
over the lateral part of the hand.
Lateral. No,
This
this
one here?
ulnar side of the hand.
Yeah,
Ulnar side, this radial side. Okay, you mean this one, right?
that's right.
Right?
Yes.
Tissue nodules. Okay, other than the soft tissue nodule, what else do you guys see? Inside the soft tissue, what is inside the soft tissue nodule here?
How far?
Good guess, but it's not trophy. Okay, this I give you some history. This is a 14 years old girl. 14 years old girl.
Xanthelasma, xanthoma.
No. So, okay. Any more answers from the floor?
Hurry up, guys. We are trying to
Short
go.
time already. I still have multiple X-ray to show.
Okay, faster, faster. Anybody? If
Okay.
it's not top five,
Nobody.
okay, nobody.
Okay, so you see there's a soft tissue nodule. Good. And then look at the
Why
other
hernia hiatus?
hernia. This is the hand X-ray.
Yeah. Okay.
Wrong group. So this is the ganglions, a good guess, but it's not. Okay, so look at the soft tissue nodule. Can you see all these calcifications?
Yes. Oh,
Okay, so
yes.
all these
Okay.
calcification, we call it fibroid. Okay, fibroid.
Police. LITH.
LITH. So it's in within the soft tissue nodules. So when soft tissue nodule with fibroids will be I think hemangiomas, soft tissue
Oh,
hemangiomas. Okay, so when you found it, then you have to look at the bone as well. This is a hand X-ray, right? So
yes.
when you look at the bone, so outline it one by one. No trauma, meaning most likely there's no fracture. So now we have to look for bony pathology. So you look at one by one, then you see on this fourth metacarpal bone, do you
Mhm.
see expansile lytic lesion here?
Yes.
Okay, so all this also, only this one, and also another one at the first metacarpal bone here. It's very subtle, but when you compare the first metacarpal with the second and third metacarpal, then you will find it, correct? It's look different, right?
Yes.
Okay, so this is a expansile lytic lesion, but the cortex is still preserved, so it's not so aggressive lesion, non-aggressive lesion. So all constellation of these findings will be that soft tissue hemangioma, and then this one will be, and chondroma, it come out to be a Maffucci syndrome.
What syndrome?
Maffucci.
How do
Maffucci, I think the spelling. Maffucci syndrome. So it's a rare congenital syndrome that the patient will present with multiple, more than one enchondromas, and also the soft tissue hemangioma. These are a real case. Very
Oh, I
interesting.
see. So
Yeah.
basically, the hemangioma has been there from birth, or it has grown with age.
It will grow with age.
Oh, so before that, it was not so big, lah.
But I don't have the earlier X-ray, only this, but it can be grown with age. Okay.
Okay.
So after the operation, so you see that the orthopedic surgeon remove the hemangioma and do some bone, remove the enchondroma and put in some the bone graft. Okay. So this
Oh,
is the post-op X-ray for this patient. Okay. So today we learn about Maffucci syndrome.
wow,
So
this is
soft
very
tissue,
interesting.
fibrotic calcification, then is point towards hemangioma, and then start looking at the bone if there's any lytic lesion, looking for Maffucci syndrome. This also exam case. Okay.
And this is also a case that you can realize that it's treatable.
Yeah, it's treatable.
Yeah.
Yes. All right. So next, this one,
Okay, the heart is big.
easy one. Okay, the heart is big. Some more, this very easy. So I
The
see more findings from the floor.
okay, come on, floor. Okay, pneumonia.
Pneumonia, okay, maybe a patchy consolidation here, okay? Then a nodule here at the right mid zone. What else? Outside the lung, anything else?
Mediating consolidation.
What is
What's
mediating?
mediating? Okay, terms have to be correct, yeah? Like description.
Mediastinum,
Oh, mediastinal.
oh no, just a mediastinum widening. So
Yes.
mediastinum widening, maybe a nodal lesion, okay, fine. So what else? So in this X-ray, other than the lung field, you see nodule here, everyone?
Yeah.
Right middle lobe and then left
How about
middle.
bones,
Oh,
the
sorry.
rib?
So this mets, lung mets.
Oh, these are lung mats.
lung mats, so there's also consolidation here. But look at outside the lung. Do you see this part here outside the chest wall?
Yes.
It's actually a fungating breast tumor. So
Oh.
there's already emphysema changes at the soft tissue here that can be shown on X-ray. Okay, so this is what I will show you today for this X-ray. All right. So remember, not only the the lung field, and then the review area, bone we already see, and then mediastinum good, and then also the outside, the lung field here.
So
Okay.
the AP is the AP sitting is the reason why the heart looks big.
Can be, it can be because of magnification. Magnification.
Yeah.
Okay, so other than these all findings, there's also bony abnormality in this X-ray. So again, one by one of the ribs outline it, so you will see a lytic lesion here.
Oh, yes.
Okay, if we don't draw and don't compare, we will already miss the lytic bone lesion. So this is a stage 4 disease. Okay. All right, come next.
Yeah, next. So
Okay,
interesting.
orthopedic.
Orthopedic. Okay, orthopedic, I really
Or alert for.
alert for.
This is an easy one.
Guys,
Yeah.
hurry up, guys. We want to do as many as we can.
Yes, now only going to the 17
Okay,
X-ray.
humerus fracture.
No.
Somebody said radial head fracture.
Yes,
Proximal.
there's radial head fracture. See, Jachi, very good. No humerus, proximal radius. This one, radial head. You see? There's a cortical discontinuity here. Very subtle. Radial head fracture is always subtle, so we must really look hard for this. Okay?
Oh, always subtle, huh?
Oh, really subtle one. We can easily miss it. So pain, and then fall, then always look for this region, the elbow, every part lah, particularly the radial head in adults.
Okay.
Okay,
Next.
radial head fracture. Next, come. What is this? An easy one.
Okay.
70 years old female, bilateral hip pains. Bilateral osteoarthritis of the hip. Okay, but what else?
Both pelvic.
Pelvic bone. Which part of the bone? Pelvic bone, there's a lot of the pelvic bones, there's a lot of component, every end of what? Which part of the bones, every end, Shafika?
Must be precise, yeah? Exam time must be precise. Proximal radius. Is this there radius here?
No, this one will be the answer from the X-ray just now, I guess.
Okay.
Proximal radius, radial head, okay lah. Dr. Hanisa.
Okay, so this one?
So this one, AVN, Shafika, you are right. Okay, so how do we look for AVN? Come, first of all, hip joint, both sides we must compare. So there's a OA changes, subchondral sclerosis, and then osteophytes, joint space narrowing, but in this case, fairly symmetrical. But you look at the femur head, it is flattened and then sclerosed. Correct? Abnormally shaped. So there's a avascular necrosis of the femur. Actually, both sides also, this also already sclerotic, but this femoral head contour is still preserved. Compared to the right side, this is already flattened. Okay? So
Okay,
this
so the answer should be bilateral
femoral head AVN.
Okay, so
The underlying osteoarthritis of hip joints. Okay, so I think no fracture here. So good, Shafika, you get a correct answer. So always remember AVN meaning sclerosis and flattening of the bones. Okay, sclerosis and flattening. Okay, what about this?
Okay, we're having more and more interaction. Very good, very good. Please. This one. Okay, the pathology, I think, is over the right.
right lower
Oh,
zone consolidation.
yes. Had the
Okay.
bypass done?
Yeah, bypass, yes. See? Is it bypass? I don't see but I can't
I don't see the bottom one, but I
see
see a
so
creeping over the.
it's very pneumatics under penetrating. So look at this consolidation of the right lower zone. Okay, I guess everyone can see. And actually, this case, I want to show you the retrocardiac opacity consolidation. But sorry for this X-ray, I didn't adjust the contrast well to show it here. Okay, so remember the review area, retrocardiac region. Okay, come for next case.
Okay.
Okay, easy one. So what is this?
You look so beautiful today, lah.
Thank you very much.
I love you so much. Okay, go on, go on.
Look
Okay,
at the
this one,
X-ray.
guys, hurry up. Don't look at her. Look at the picture.
Yeah, look at the X-ray.
Please.
So this is a very easy one. Come on, abdomen X-ray.
Into susception.
No.
Oh,
Yes, valvular conniventis. So when present of valvular conniventis, so what does it mean? Is the bowel loop dilated or not dilated?
oh, I don't think I've ever heard this term before.
Valvular conniventis is the small bowel fall.
Okay, so
So
anyone?
this is, guys, this is a very small bowel obstruction. Yes, correct, everyone. Thank you for the answers. So this is a dilated small bowel loop with this very beautifully imaged
Like,
valvular conniventis here. Okay,
or
so
like
this,
a stack of coins.
yes, also small bowel obstruction. All right.
Okay,
So
good.
you don't see also. So when you look at the abdomen X-ray, look for dilated bowel, and then next normally I will look at the pelvis region here if there's any air in the rectum. If there's air in the rectum, normally maybe subacute obstruction or no obstruction. So but in this case we don't see. So it's a definite small bowel obstruction. Okay. So you see the abdomen here also increased density, and then the psoas outline are not clearly seen, may indicate underlying ascites as well. Okay. So this is a very beautiful small bowel obstruction X-ray. So okay, again, next, a large fall and then left hip pain. Okay, come on, guys. So when I show you bone or pelvic bone X-ray, then with the fall, definitely need to look for fractures, right? Acetabular wall fracture, not accurately correct. So which part of the bones are fractured? So if we cannot find left pelvic brim, which part of pelvic brim you are talking? You may be correct, but which part? So for me, pelvic brim will be this region, but where is the fracture? So for pelvic bone, for fracture, the location must be accurately informed or mentioned. So draw the line following the pelvic. This is what iliac crest. Okay, and then coming down here towards the acetabular wall, and then the pubic rami here, superior, inferior pubic bone, and then the femur. So still cannot see, then you compare one by one. Left iliac crest, this part is iliac crest. There's no fracture here, it's fairly symmetrical. So there is a avulsion fracture here actually at the left ASIS, anterior superior iliac spine. So do you see the avulsed bony fragment here? Compared to the right side, there's nothing coming up. And then you will see some loosen changes here because of the fracture. Okay. So this is the next X-ray in the oblique view. Then you will see clearer picture of the avulsion fracture of the ASIS. Okay. So good guess, Shafika. So next,
Not guess lah.
Masi, you did answer also.
Okay. I'm
Busy. Okay, what
busy.
about
This one?
one? Let me
This one I
see.
think you've shown before.
This one. No, this another patient.
Oh, this one, the left cardiac silhouette got no consolidation.
No, this one nothing, but this one
Yeah.
I think I'll show this nodule only actually. Okay, so don't forget to look for small nodule when you see X-ray.
So you
Okay,
mean that fibrotic looking thing is normal?
which one? Here, down
Yeah,
here.
that's right.
This one here. This not
Yeah.
normal. This is also fibrosis.
This one, is it fibrosis?
Yeah, this fibrosis, but
Okay, fine.
there's a nodule here. And then other than that, actually, I'll show you the nipple outline, both sides symmetrical. Okay, last time we talked about the nipple outline in our several X-rays, right? So
Oh,
again, because the day I saw a patient, actually it's a nipple outline, but referred to a chest physician for a lung nodule.
okay.
So remember, must look for it. If not sure, repeat the X-ray with a nipple marker. Okay, so come next. Okay, this we showed already just now. Come tell me the answer, everyone. This is another patient, but with same pathology.
Wow.
What is this?
The spine.
Not the spine. The spine is a degenerative changes, and then with
Yeah, under the diaphragm.
dislocation. And the diaphragm, yes, pneumoperitoneum. So again, I'll show you this is the gross pneumoperitoneum. Okay, no one should miss this again. All right.
Wow. Well
Okay.
done,
Next.
guys.
Hmm.
Proud of you guys today.
Okay. What about this? So what catheter is this?
Guys, hope a DJ stand.
DJ stand, SPC. No, there's no SPC. Yes, there's DJ stand here. This is the DJ stand. Okay, connecting from the renal pelvis along the ureter and then into the urinary bladder. So this is the nephrostomy tube. Okay, this one connecting from the externally to the kidney will be a nephrostomy tube. And then this is the DJ stand. So, but in this X-ray, I'm going to show you is this dilated bowel loop again. Okay, so here also, so other than the tube and all, we also need to look at the bowel loops in the abdomen X-ray. So this is also bowel obstruction, small bowel obstruction here.
Small
So,
bowel also.
because you see the valvula conniventis
Oh, okay.
across the whole lumen, and then there's air fluid level here. Okay, so in this case, we have seen nephrostomy tube and a DJ stand, and then the small bowel obstruction. Okay, come next. Okay, what about this? Cervical X-ray, neck pain, no history of trauma.
Hey guys, spondylosis.
Huh? Who answers spondylosis? Dr. Betty?
Me.
Yes, correct. Some more?
Correct.
Definitely will have spondylosis. Okay, what else? Do you see something is actually missing?
Oh, I think you showed this before.
No, this I never showed this before.
You never showed this before. Come on, guys.
So I already told there's something missing. So what is missing here? Come on, guys. We are running out of time.
So the yeah. There's
Sleep
not some.
is
Yes.
sleep
Somebody said the
day.
C3 vertebral body. I also agree.
C2, 3 is not 3. 2 is here. This is 3.
Sorry?
One level below the 3.
So it's 4.
C4.
Yes.
Yeah. So C4 is missing. Okay, so it's disrupted already. It's a bone mass here.
I
Okay, so
see.
when you look, when you see a cervical bone X-ray, must always again outline the bone one by one. Then only you will see the missing one. If not, you will miss it also.
Okay,
Okay,
where is one? Can you show me one?
one we cannot see. One is a ring,
Oh, I see one you can't
and
see.
then
So
two
you can see it's
odontal
already
process.
two
So
lah.
this is two straight away.
Okay,
Two, three, then four missing, five, six, seven. Okay, so
okay.
showing the this lytic destructive C4 vertebra bone mats. Okay.
Oh, very good.
This one we must finish this X-ray by today. Again, this is about the review area again.
This is the splaying of the carina.
Yes, very good. You got it right. Okay, everyone. Again, lung field quite clear, and then some fibrosis at the right lower zone, doesn't matter. And then corsophrenic angle clear, so review area apex, okay, then mediastinum, and then trachea. So there's a splaying, is widened. This one we showed during the last session as well.
Yes, I know. I can see the mess from the last session. My memory is not bad.
Very good.
Oh.
So that's playing. So the carina not supposed to be like opening this wide compared to, let's say, okay, this X-ray, you see the carina is not so widely open up, right? So going back to our X-ray, you see this is playing widely open carina. So there is a mediastinal nodal mass here. Okay, remember when I look at X-ray, trachea also is the review area, and then the carina angle is
Why
widening.
this trachea is so obvious, huh?
So obvious.
Yeah, compared to other pictures, you see all the
Also,
carinas are not so
see
like
this
you see,
one.
not that obvious, but this
Not the
one is,
obvious method. Maybe the penetration also.
yeah, maybe the
Okay,
penetration.
this one also not so
Oh,
obvious.
that's right.
Yeah, this one still okay, can see.
Okay.
We going back to our X-ray just now. So this is a widely like splayed carina. At the same time, there's also right paratracheal opacity here.
Oh,
Okay, these are also the nodes. Okay, so going to the CT of this patient, you see there's a huge multiple metastatic nodes at the mediastinum as well as the both hilum here. Okay, so this is the nodal mats in this case. So again, remember, look at the carina angle and then some opacity filling up at the whole mediastinum. I think this is a lymphoma patient. Okay. Lymphoma or mets. Okay. So what about this?
oh, this is multiple lytic lesions, bony lytic lesions.
Bony lytic
No,
lesion. Yes. Some more?
some more.
Mm.
Nice,
Guys, come give me answer.
faster.
Everyone must get the correct answer for this case.
Okay.
Alert 4.
What came in for alert fall?
Alert 4, yes. Yes, Farisa, you got it right. Left neck of femur fracture. Okay, so here,
Oh my
you see?
God.
So again, in this case, Shenton line, very important, draw it. Then compare both sides. See, you can't draw the Shenton line on the left side. It's fractured and then impacted. Okay, so we cannot miss a neck of femur fracture.
So
Okay?
is this because of pathological fracture
Yes.
due to
No,
mets?
due to maths. But in non-pathological fracture, also neck of femur fracture is very common in osteoporotic patient and in elderly as well.
Yes, okay.
Okay, so neck of femur fracture. So everyone, very good that you can get the correct answer. So for pelvic X-ray, always draw the line and then the Shenton line as well to make sure there's no neck of femur fracture. Okay, next. So what about this?
Oh, there's a left upper lobe. Is it a
Consolidations.
Consolidation.
Okay, consolidation with air bronchogram within. So this is an infection. It's just pneumonia case. And then what else in this X-ray we can see? You see already mediastinum quite okay. There's no splaying here. So look at the bone.
Anyone?
Anyone? Bone?
Bone.
Yeah, bone. Draw the ribs one by one. 1, 2, 3, 4, 5, 6. There's a O fracture with callus here.
Ah, okay.
Okay. All right. So the rest are normal. So in this X-ray, we're learning about the consolidation and then the bony O fractures here.
Basically, we're just trying to
Review.
build a system where we review every single,
Yes,
yeah.
we
I
review
think
the
that,
X-ray. Okay.
okay. Anyone else? Any more?
Wait, I'll show you one more. Not this one next time.
Yes. Oh,
We are lack of time. I want to show you. Okay, this one. Come.
okay, guys. Come on. Last one, Eddie.
Yeah, last one.
But you all did very well today, lah.
Yeah.
First,
Okay, Jachi, you got it right. The just now the X-ray, right?
yeah.
Come look at this.
All of you did kyphoscoliosis.
Policies. Okay, good.
Okay, that's
But
one.
there's something else I want to show in this X-ray.
Okay.
I think I was seeing two yellow line on the screen. I saw it. Is it there?
Yes, yes. I think somebody, I don't know why sometimes
How can
somebody,
they? Oh, what
I don't
happened?
know, I can't get it. I can't clear it one. Sometimes somebody will draw something.
Accidentally draw, is it?
Yeah. Okay,
Come,
anyone,
everyone.
please hurry up.
So for this last X-ray of the day.
Come on, make our day.
Yeah.
Cheer here. Okay, somebody, Arif Mokhtar said, right fourth posterior rib fracture.
No.
Uh,
Pure effusion, right?
CM said left and
No.
fracture.
Left what? NOF? No, that one will be the just now the X-ray, I think.
Oh, I see.
Earlier one. I think came in late.
Okay, right pleural effusion.
No, the cosophrenic quite clear in this X-ray.
Okay. Oh yeah. Oh, so they the O fracture one, yes.
Lung collapse. Which part of the lung collapse? Right or left? Or which segment must be
Okay.
clearly
Must
answered.
clear. Okay,
Right.
Asliza said right. Right what?
Yeah, right what?
Asliza, you cannot answer no Fariza's lung collapse. You need to give us the full.
Yeah, which part of the lung? Right
Yeah.
upper lobe collapse, right lower lobe collapse. This one is about review area.
Okay, Jabal said right upper lobe collapse.
No, if there's right upper lobe collapse, you will see a golden S sign with the whole right upper zone will be opaque. Okay, so this case, you see both upper zone is fairly symmetrical, the density, so there's no collapse here. Okay, so what else? Review area.
Is the diaphragm over the right elevated?
Right, lower lobe mass consolidation. I guess you're talking about this, right? No, it's quite okay because of the rotated view and plus patient is having scoliosis, right? It's still acceptable. Normally, we will take it as more than 2 cm different between the right and the left diaphragm, but this case is still okay. Okay, so what else? Review area, come.
Yeah, review upper lobe. No pneumothorax, looks the same. Both lung field look same density. The silhouette of the Postchondral junction are clear. The heart silhouette over the left side is normal. The right side looks fine. Mediastinum looks
Not widen.
not widened. Carina. Okay, Shafika said left lower lobe collapse.
No.
No, I don't
As
think.
the envelope collapse, you will see a sharp triangular line with opacity here at the retrocardiac region. So that's this retrocardiac region is fairly clear in this patient, so it's not collapse. So there's no collapse in this case.
No collapse in this case. So now the lung I've already gone through. I'm going to
Yes.
look at the bones now.
Please.
Wait, let me see where.
Come on, guys. Are you guys looking as well?
No,
Looking hard?
I'm really hard looking hard for the first time.
Our participants today.
Are you looking or not? I'm looking hard at the
Please
bones
looking.
now.
See who is the fastest to get the correct one.
I think I see lytic lesions in the ribs.
Where?
Okay, over the right side, near the cardiac.
You mean this part?
No, the neck up. That. Lower. Right clavicle fracture.
No, there's no fracture here.
Okay.
It's not
Go
trauma.
down, right side, go down. And the next one, here. The low, go to the right a bit. No, up. This one.
This one?
Yeah.
No, that's just overlapping.
Okay.
You will see the outline, the cortex outline here still can be seen.
Oh, I see. Okay. So,
Okay, so give you guys hints on the left side. Everyone looking at
okay,
the right
left side. Come on.
Come
Left
on.
side.
Count the ribs, please.
Count the ribs. Count the ribs, please, guys. Oh, ribs are counter.
Count, outline the ribs, then you will see.
Okay, guys, it's already give you hint already.
Yeah.
Count the ribs. Hold on. I can't.
Outline the ribs, then you will see. Come on, guys.
Left fifth rib fracture.
Not trauma case. There's no fracture. Yeah, there's kind of fracture. Okay, left fifth ribs. Somebody already draw it, you see?
Oh. Wow,
Good.
who drew it? Now erase that. Go and erase that. Whoever drew it. Okay, thank you. Okay, can see.
Can see already?
Can
She already draw it?
still. Is that fifth rib fracture?
No.
It's not the fifth, if not the fourth. Whoever drew it but didn't.
He didn't answer, he just drew it, but he
Oh, I see.
drew
Okay,
the correct one. Okay, so
okay.
I'll give the answer now. First rib, second rib. Here is missing already with the expansor soft tissue lesion.
Oh, yes.
Ribs is missing out already eroded by this mass. So this is a bone mass.
Who drew this? Please put up your hand.
Now, come show us
Show
your
your,
name.
tell us.
Very good.
Who drew this?
Okay, so third one is the third rib. You still can draw it very nicely.
Kok Rui. Well done.
And okay, so 1, 2, 3, 4 ribs here following. Okay, then 1, 2, 3, 4, 5, fifth ribs also quite okay. See the outlines you can be seen.
Oh,
So
yeah.
there's the eroded second ribs with a soft tissue mass here. Is a destructive bone mass. Okay.
Okay.
So
Even
review
okay.
area and
In
then
Facebook also, Ong CM and Arif Mukhtar also said the one below the left clavicle and then the second lytic lesion.
yes,
Okay,
correct.
not bad, guys.
Okay.
I'm very happy today because the interaction was very good. Everybody participated, and then the audience, the number of audience also still maintaining despite the fact that we have had so many
Quick
sessions.
questions. Yes. So every day I'm looking interesting X-ray to show you guys.
Yes, and we also I have also done this webinar for about 3 years plus, and the audience still coming in, so I'm very happy. But next week will be our last session for this year. Oh my God. So,
So fast, right? This year passing very fast.
oh,
It's
yeah.
25 soon.
I'm going to stop live stream now and then stop recording.